Most men believe that anatomical size is the primary factor in sexual satisfaction. If you're over age 50, I need you to understand something important. The advice you've been following, it was designed for younger physiology, and it may actually be working against you. Hello, gentlemen. I'm Dr. Rena, men's health advisor with 15 years specializing in male sexual dysfunction. And today, I'm sharing 4 position modifications that work with age-related vascular changes instead of fighting them. Now, before we begin, I need to be clear about something. If you're experiencing persistent erectile dysfunction, meaning you cannot achieve or maintain an erection sufficient for intercourse more than half the time, you should consult with a physician. ED can be an early warning sign of cardiovascular disease, diabetes, or hormonal imbalances that need medical evaluation. What I'm discussing today, well, these are technique adjustments for men who can achieve erections, but struggle with maintaining them during intercourse. This is about optimizing what's working, not replacing medical treatment for what's not. That said, there's a common misconception I need to address. The traditional focus on deep penetration, it's based on outdated assumptions about female sexual anatomy. Research published in the Journal of Sex and Marital Therapy by Komisaruk and colleagues found that the majority of mechanoreceptors, the nerve endings responsible for sexual sensation, are concentrated in the outer third of the vaginal canal. This is approximately the first 2 to 3 inches. For men over 50 who typically experience some degree of reduced vascular flow due to age-related endothelial changes, this is actually advantageous information. As we age, the tunica albuginea, the fibrous sheath surrounding the erectile tissue, becomes less elastic. This is normal aging, not pathology. Additionally, the smooth muscle cells in the corpus cavernosum begin to be replaced by collagen fibers, which, well, it reduces the blood trapping capacity. High-velocity deep thrusting requires significant cardiovascular output and can actually promote venous leakage in men with reduced tunica elasticity. So, what I'm going to show you today are 4 positions that minimize venous outflow while maximizing stimulation of the nerve-dense zones for both partners. Before we continue, please like this video if you're finding this information helpful, and leave a comment telling me where you're watching from. Let's talk about the physiology first, then we'll get to the practical applications. To understand why these positions work, we need to understand what changes physiologically after age 50. In younger men, erectile function relies primarily on robust arterial inflow and efficient veno-occlusion, the trapping of blood within the erectile chambers. The cycle goes like this. Sexual arousal triggers nitric oxide release, which causes smooth muscle relaxation in the arterioles. Blood flows into the corpora, and as the tissue expands, it compresses the venules against the tunica albuginea, trapping the blood. This is called the veno-occlusive mechanism. As we age, several things happen. First, endothelial function declines. The cells lining your blood vessels produce less nitric oxide, which means the smooth muscle doesn't relax as efficiently. Second, the tunica albuginea loses elasticity. It doesn't compress the venules as effectively, leading to what we call venous leakage. Third, we see an increase in phosphodiesterase type 5 activity, which breaks down the chemical signals that maintain erections. The result, erections that are adequate to begin intercourse, but difficult to maintain with vigorous activity. Now, here's what most men don't realize. High-impact thrusting, especially with full withdrawal and re-entry, creates a pumping action that can actually worsen venous leakage. Each time you withdraw significantly, you're reducing the internal pressure that's keeping blood trapped in the erectile tissue. A 2018 study in the Journal of Sexual Medicine by Capogrosso and colleagues, they examined erectile rigidity during different coital movements in men aged 50 to 70. And they found that men who maintained shallow penetration with minimal withdrawal, they preserved rigidity significantly longer than those who used deep, high-amplitude thrusting. The mechanism is straightforward. You're maintaining consistent intraviral pressure. Additionally, and this is important, neurological sensitivity actually increases with age in many men. While vascular function declines, tactile sensitivity often improves, particularly in response to sustained pressure rather than rapid intermittent contact. This means that the positions I'm about to show you, well, they aren't compromises. They're actually optimized for mature male physiology. Let's look at the first position. Position number 1, the modified posterior entry. The first position is a modification of the posterior entry position, commonly called doggy style. Traditional posterior entry requires significant core engagement and often encourages deep thrusting due to the angle. In the modified version, both partners lower their center of gravity. Your partner assumes a prone position with the pelvis elevated slightly, either with a pillow or wedge. You position yourself with a lower angle of entry, bringing your torso closer to your partner's back. This creates what I call anterior-posterior compression. Here's what's happening anatomically. At this angle, the glans and shaft are making consistent contact with the anterior vaginal wall, where the urethral sponge and periurethral glands, sometimes called the G-spot area, are located. These structures have high concentrations of mechanoreceptors. For you, this position allows for small amplitude movements. We're talking 2 to 3 inches of excursion maximum. This minimizes venous outflow while maintaining stimulation. You're using your body weight to create pressure rather than momentum. One of my patients described it this way: instead of feeling like I'm working hard and losing ground, it feels effortless and I stay firm the entire time. That's the veno-occlusive mechanism working in your favor. The key is understanding that you're not generating force through velocity. You're generating sensation through sustained pressure and consistent contact with nerve-rich tissue. Position number 2, the coital alignment technique, CAT. The second position is based on research originally published by Pearson Halbert in 1991, and it's been studied extensively since. It's called the coital alignment technique, or CAT. In standard missionary position, the pelvic structures are not optimally aligned for clitoral stimulation, and men often resort to high-velocity thrusting to compensate. In CAT, you shift your body position superior to the standard alignment. Your pelvis should be higher than your partner's with the base of the penis in contact with the man's pubis and clitoral complex. Instead of thrusting, you perform a rocking motion. Think of it as a coordinated forward and upward movement rather than in and out. Here's why this matters physiologically. The clitoris has approximately 8,000 nerve endings concentrated in a very small area. By maintaining constant contact with the clitoral shaft and glands, you're providing continuous stimulation rather than intermittent contact for you. This position has significant vascular advantages. Because the movement is rhythmic and low amplitude, you're maintaining consistent intra-avernosal pressure without the cardiac demand of vigorous thrusting. A 2014 study in the Archives of Sexual Behavior found that men over 55 using pressure-based techniques, they maintained erectile rigidity 40% longer than those using traditional thrusting patterns. The mechanism is simple. You're working with your vascular limitations rather than against them. Additionally, because both partners are engaged in a synchronized movement pattern, there's increased proprioceptive feedback. Your nervous system is getting constant positional information, which enhances arousal through non-genital sensory pathways. This is sometimes called whole body engagement. For men who experience performance anxiety, which is common after age 50, this position can be particularly helpful because it shifts focus from "am I hard enough" to "are we moving together?" That psychological shift, it often reduces sympathetic nervous system activation, which can interfere with erectile function. Position number 3, the lateral recumbent side lying. Position 3 is the lateral recumbent position, sometimes called spooning. Both partners lie on their sides in the same direction with posterior entry. This is what I call a gravity-neutral position. Let me explain why that matters. In upright or semi-upright positions, your cardiovascular system has to work against gravity to maintain blood flow to the pelvis. This increases cardiac workload and can accelerate fatigue, particularly in men with any degree of cardiovascular compromise. In the lateral recumbent position, the heart is at approximately the same level as the pelvis. This reduces the pressure gradient and makes it easier to maintain arterial inflow. From a veno-occlusive standpoint, this position also has advantages. The angle of entry naturally limits penetration depth, and the intertwined leg position creates external compression that can actually assist with venous occlusion. Think of it as external support for the veno-occlusive mechanism. For men over 60 or those with any cardiovascular history, this is often the most sustainable position. You can maintain it for extended periods without significant cardiac strain. One additional benefit, your hands are free for additional stimulation. We know from multiple studies, including work by Brody and Costa in the Journal of Sexual Medicine, that combining vaginal penetration with manual clitoral stimulation, well, it significantly increases both partner satisfaction and orgasm reliability. This position makes that coordination easy. For men concerned about duration, and that's most of my patients over 50, this position allows you to modulate your arousal level more effectively because the movement is controlled and the cardiovascular demand is low. You're not fighting fatigue, so you can focus on sensation and timing. Position number 4, the reverse supine with anterior angulation. The fourth position involves your partner in a superior position facing away from you. This is sometimes called reverse cowgirl, but I'm going to modify it significantly. Your partner should lean forward at approximately 45 degrees, ideally supported by a wedge pillow or cushions placed at the foot of the bed. Here's the physiological advantage. When your partner leans forward in this position, it creates an angle that directs pressure toward the anterior rectal wall, which is where your prostate is located. The prostate contains high concentrations of nerve endings and is sometimes called the male G-spot, though that's not technically accurate terminology. What matters is that sustained pressure in this area can generate significant arousal through a different neural pathway than penile stimulation alone. From a vascular standpoint, this position is unique because you are completely passive. You're not generating the movement, which means your cardiovascular and muscular systems are not under demand. All of the vascular energy is going toward maintaining the erection rather than fueling muscular activity. Additionally, gravity is working in your favor. Blood pools in the pelvis without requiring active circulation, and the suspensory ligament is under mild tension, which can enhance the perception of rigidity. This position also gives your partner complete control over depth, angle, and rhythm. For men who experience anxiety about performance, transferring control can actually reduce that anxiety and improve erectile function. The sympathetic nervous system, which governs the fight-or-flight response, can inhibit erectile function when overactive. By reducing performance pressure, you're reducing sympathetic tone and allowing the parasympathetic nervous system to dominate, which supports erectile function. One caution: this position does require your partner to have good hip mobility and core strength. If either of you experience discomfort, stop and try a different position. Sexual activity should never cause pain or strain. Now, let me give you 3 enhancements that can improve outcomes across all 4 positions. First, the pelvic wedge. A foam wedge placed under the pelvis can change the angle of entry by 15 to 30 degrees. This seemingly small change, it can significantly improve alignment with nerve-rich zones and reduce muscular strain. These are widely available and typically cost between $20 to $50. The angle change also assists with venous occlusion by optimizing the position of the tunica albuginea relative to the venous drainage system. Second, the respiratory technique. Nasal breathing stimulates nitric oxide production in the paranasal sinuses. Nitric oxide is the primary signaling molecule for erectile function. It's literally the mechanism by which medications like sildenafil work. During sexual activity, focus on slow, controlled nasal breathing rather than holding your breath or breathing rapidly through your mouth. This maintains nitric oxide availability and reduces sympathetic nervous system activation. If you find yourself holding your breath during exertion, that's a sign you're working too hard and potentially impairing your own vascular function. Third, the temperature factor. Vascular function is temperature sensitive. Cooler environments cause peripheral vasoconstriction, the narrowing of blood vessels, which reduces blood flow to the extremities, including the genitals. Maintain a comfortably warm environment, typically around 72 to 75 degrees Fahrenheit. This promotes vasodilation and reduces the cardiovascular work required to maintain adequate blood flow. These may seem like minor details, but vascular function in older men often operates on narrow margins. Small optimizations can make meaningful differences. Let me summarize the core concept that ties all of these positions together. I call it the principle of minimal excursion. In every position I've described, the goal is to minimize the distance traveled during each stroke. This serves two purposes. First, it maintains intravenosal pressure by reducing venous outflow. Every time you withdraw significantly, you're allowing blood to escape through the venous system. By maintaining shallow penetration, you're keeping that blood trapped. Second, it maximizes contact with the nerve-dense zones that matter most for sexual sensation. The outer third of the vaginal canal, approximately 2 to 3 inches, contains the vast majority of mechanoreceptors. Deeper penetration doesn't increase stimulation proportionally, it just increases cardiovascular demand. A useful analogy. Imagine you're trying to maintain pressure on a hydraulic system. Every time you release pressure and then rebuild it, you're losing efficiency. By maintaining constant controlled pressure, you're working with the system's design rather than against it. That's what we're doing physiologically with these positions. Before I close, I want to be very clear about when these techniques are appropriate and when medical evaluation is necessary. If you are experiencing any of the following, please consult a physician. Inability to achieve an erection sufficient for penetration more than 50% of the time. Complete loss of morning erections. Sudden onset erectile dysfunction developing over weeks rather than years. Erectile dysfunction accompanied by chest pain, shortness of breath, or other cardiovascular symptoms. Erectile dysfunction with decreased libido, fatigue, or mood changes. Potential hormonal issues, painful erections or curvature of the penis, potential Peyronie's disease. Erectile dysfunction can be an early warning sign of serious cardiovascular disease. The blood vessels in the penis are smaller than those in the heart, so vascular damage often shows up as ED before it presents as cardiac symptoms. What I've discussed today addresses the normal age-related changes that occur in men with healthy vascular systems who are experiencing mild to moderate difficulty maintaining erections during vigorous activity. This is not a substitute for medical treatment of erectile dysfunction. If you have questions about whether your symptoms warrant evaluation, err on the side of caution and see a physician. Many men avoid seeking care due to embarrassment, but ED evaluation is routine medical care, and early intervention can prevent progression. Gentlemen, sexual function changes with age. That's not failure, that's physiology. The question is whether you're going to work against those changes or adapt your approach. What I've shared today are position modifications based on our understanding of age-related vascular changes and female sexual anatomy. They're designed to optimize sensation while minimizing cardiovascular demand and preserving venous occlusion. If you found this information valuable, please like this video and subscribe to this channel. I release content regularly on evidence-based approaches to men's sexual health. And remember, if you're experiencing persistent difficulties, consult with a healthcare provider. These techniques complement healthy physiology. They don't replace medical treatment for dysfunction. I'm Dr. Rena, your men's health advisor. Thank you for watching.